Good morning, all of you. Good morning to the President and the dignitaries. I take this opportunity to thank DFood International for giving me an opportunity to talk on such an important topic of diabetic foot and how elective surgical management of diabetic foot can prevent amputation prevention. As a surgeon, I am doing lot of these procedures in India. My training in US has helped me in learning these techniques which I am implementing in India. India being the diabetic capital as well as low and medium income group country, I believe that because of very high cost of footwears as well as inadequate coverage by the insurance companies in these countries, surgical offloading as an elective surgical management of diabetic foot will definitely help us in amputation prevention. We have seen that lot of things have been sent in and talked about prevention of diabetic foot amputations. There have been recommendations in different articles that governments have to revise health policies. There should be introduction of new education curriculum. There should be allocation of health budget for non-communicable diseases, implementation of patient awareness strategies, enforcement of catch them young policies in medical colleges. I, with the help of Dr. Nair, Dr. Abbas, Dr. Vijay, initiated this program which we had declared in Madrid, Spain, in India, in spreading awareness and education in various medical colleges in India through online programs as well as physical programs, and establishment of diabetic foot clinics. This will all help in prevention of diabetic foot. But if government policymakers or organizations merely make promises without implementing changes, what can physicians and surgeons like you and me do for diabetic foot patients who return year after year with trust? How should we respond when they develop foot disease? Prevention remains the most effective approach, and this has been also included in the International Working Group of Diabetic Foot Guidelines as well as the Indian Guidelines ICMR 2015. It has been concluded that multidisciplinary approach and prevention are going to be very important for the future in the management of diabetic foot, a complication which is increasing enormously in the patients of diabetes. So, can a surgeon like me be a part of preventive management of diabetic foot? Certainly, if the multidisciplinary team aims to identify deformities, correct them, detect areas of high foot pressure, and perform surgical interventions to reduce pressure and prevent ulcer recurrence in accordance with IWGDF guidelines 2023. The International Working Group in Diabetic Food Guidelines 2023 have given clear and simple recommendations for preventive strategies. One of them is to detect higher risk diabetic foot patients if they have got abundant callus, ingrowing toenails, and fungal infection, to treat them as preventive mechanisms. Patients having non-rigid hammer toes mallet toes. You should also use surgical tenotomies, flexor tenotomies, Achilles tendon lengthening or gastroc release if the conservative treatment is failing, and if you have a demonstrable high risk foot with high pressure in the forefoot. Patients whose wounds are not healing with conservative management and footwear, patients where the ulcer is recurring, you can use this Achilles tendon lengthening and gastroc release surgical offloading methods to treat. Even metatarsal head ulcers, which are on the plantar and which are not healing, we can do metatarsal head excision. They have also said that don't use a nerve compression procedures for high risk foot and patient who have high risk foot and ulcer not healing and having painful neuropathy to give standard of care rather than doing nerve decompression. The surgical intervention for chronic deformities and ulcerations is an important component in management of diabetic patients as a preventive strategy, and thanks that it has been included in the DFoot International Guidelines of 2023 if the conservative treatment fails. The outcome of these interventions are fairly predictable when patients are properly selected and evaluated, especially the blood supply. We have also included this as a special recommendation in ICMR Indian Guidelines of 2015, which will be now renewed. The classification of diabetic foot surgery, as we all know, classified by Dr. David Armstrong and Frickberg, are four classes: elective, prophylactic, curative, and emergent. So, we are going to talk today about the elective and prophylactic management. In India, a decade ago, corrective surgeries were not done in a very high quantity or volumes, but now people who have been trained in US are doing these surgeries, and we have started also imparting training to Indian surgeons. We get foot like this foot with atrophy on dorsal forefoot, development of hammer toes. We have foot which are having cavus appearance, developing high plantar pressures under prominent metatarsal head and contributing to hammer toe, mallet toe. A patient with great toe amputation can develop deformities also, with which can be corrected with different procedures, as I mentioned, of flexor tenotomy, tendoachilles lengthening, as well as gastroc lengthening. So we have certain deformities like hammer toe, claw toe, mallet toe, which are known to increase pressure associated with neuropathic ulceration. Now, if these deformities are not rigid, they are flexible deformities or soft tissue, then you have to do correcting structural deformity surgery with resection arthroplasty, percutaneous flexor tenotomy, and which will augment healing and reduce risk of ulcer recurrence. So we have certain evidence of limited ankle joint mobility we come across when we examine the foot clinically, and we see that the Achilles tendon or gastrocnemius soleus complex is tight. We do silver cords test to find out where is the tightness, and accordingly we do release as surgeons the tendoachilles or gastroc release. We also do hammer toe correction by resection arthroplasty. We correct the deformities like bunion and claw feet. This is a very simple procedure of tendoachilles lengthening, which we do percutaneously now, not an open procedure, and it has to be learned and carried out. Gastroc release also a simple procedure that we follow. There is evidence, but in 1996 as well as more recently in 2024 by Mueller. These are some of the studies which show that doing resectional arthroplasties or doing percutaneous Achilles tendon lengthening and even supplementing the percutaneous lengthening with total contact cast decreases the recurrence and helps in decreasing the foot pressure, thereby preventing ulcer reformation. This was Mueller's study which showed a decreased recurrence from 81% to 38%. It was done in 2003-2004. Gastrocnemius resection is a simple procedure. Medial part of the leg, we take an incision and there we release the gastrocnemius, and you can find the ulcer healing with the help of footwear and this procedure. Flexor tenotomy is a very simple procedure. We can also perform by taking a 18 gauge needle, and you find the toes which are curved become normal and prevent a ulcer because of friction on the footwear. This is a small video which will demonstrate
sir.
how procedure is done.
Tight ga madandi.
So this
Tight ga. Okay. So as a patient to make a tight fist, flex.
where
See,
18
I have released
needle is
tendons.
used to
Two
release
tendons.
the
See,
tendon,
you can
and you can see
you can
that
feel.
there
I can
is
feel
a
the
this tendon
given
is,
away feel. So the tendon tight kar. Only by doing a sweeping motion you can release the tendon.
see the motion,
The contracted
just a
tendon.
transverse
See, I am
motion
doing
to
this.
cut the
Another 26,
and
another
that is how
16.
it
See,
got
this is
corrected. So
this is
this
okay.
simple
Hey,
procedure
madam,
is can be done. Then arthroplasties, you can do Keller's arthroplasty that has been demonstrated, and this Keller's arthroplasty where the proximal part of the proximal phalanx is removed, so the windlass mechanism which is causing a loss of windlass mechanism which is causing the recurrence of great toe ulcer is corrected and we don't get ulcers. This is out of box thinking. Hind foot ulcers which cannot be surgically offloaded you can use a rotation flap technique where you can excise the ulcer and then have a rotation flap where, like plantar's skin, which is a specialized skin, the like tissue is replaced by like tissue, where this flap is folded and it is sutured, and you get. This is a video of the rotation flap technique that was done, and it showed that after the flap was closed, the like tissue was replaced by like tissue. This was done in 1996, and this is how we got a very good skin after doing this surgery. And the same patient on the other leg had a deformity where we did a fillet flap on the toes, and the toes were all removed and the flap was closed, and we did a tendo Achilles lengthening for this patient. Though this patient was not recommended to dance or do something, but he was so excited that he was doing this performance during his daughter's marriage. So this is how it helped him for the next 12 years. He had no recurrence. Metatarsal osteotomy is also a good procedure which neuropathic ulcerations under metatarsal heads, which is a challenging problem to heal. So we do metatarsal head resection mostly from the dorsal side, but sometimes we have to do it from the plantar side if there is a active ulcer. We use simple instruments like bone cutter, hemostat to do this resection. We can give this patient a window PCC and it can cause healing and reduction of time to heal as well as recurrence. So different metatarsal head papers have been submitted. Armstrong and his colleagues reported more rapid healing and lower recurrence rate in surgical group as compared with non-surgical care. These are some of the cases that has been come in the literature where the metatarsal head was removed and the patient was given offloading. Pan-metatarsal head resection is also been done in patients with multiple ulcers uh, where you can prevent ulceration in the future. The good news is in India we have now trained surgeons in Southeast Asia. We have started doing preventive surgeries, healing ulcer by arthroplasty and TA lengthening, correcting deformities for accommodation in footwear and decreasing pressure, decrease foot pressure by surgical offloading. Elective is a upcoming technology or technique which should be implemented in preventing diabetic foot complications and healing and recurrence. Charcot foot, which we all know is a continued stress of weight bearing leading to more fractures, dislocations, and deformity. And in later stages, we always recommend surgical corrections, as in especially in our climate where total contact cast, the tolerability is less, the compliance is less. So wherever possible, we do surgeries like simple plantar exostectomy with or without tendon Achilles release, midfoot realignment orthodesis, hindfoot orthodesis, ankle orthodesis, combination procedures most often required as Charcot deformities usually are multi-level. So we have this simple procedures of doing a simple exostectomy for a midfoot ulcer with prolapse of the bone. We also do a technique which is famous where a circular external fixation is placed after dialectectomy and fusion of the ankle foot is done by external fixator, a circular called Ilizarov technique. We also do simple bumpectomy surgeries, giving the shape and the arch back to the patient. And nowadays we have different new techniques which have come, a Masquet's procedure, then tibial transfer techniques, which definitely should be included in the armamentarium of the surgeon. The conclusion is the surgery on ulcerated or deformed foot has assumed an increasingly important role in the management of diabetic foot. Diabetic foot patients with peripheral neuropathy or ischemia at a high risk for complications than non-diabetics. It can be used. Careful patient selection and thorough foot evaluation are cornerstones of achieving success. Surgical intervention on deformed foot can obviate many months of unsuccessful conservative care, and antibiotic stewardship should also be practiced in today's diabetic foot management. To end, early detection and protection of high pressure areas in the foot and corrective footwear, orthotics, and now elective surgery is the only strategy which I see to prevent loss of limb in diabetic foot. We in India, we have now started, along with Diabetic Foot Society of India, a Podiatric Surgical Society of India, which is recognized by the American Podiatric and International Podiatric Group. And we are thankful to Dr. Bal, Dr. Sanjay Vedya, Dr. Sanjay Sharma, Dr. Rajesh, myself, who are now trying to propagate podiatry in India in a big way, including diabetic foot management. So these efforts with a multidisciplinary approach, physicians, surgeons, orthotics, will go in a long way in preventing amputations in diabetic foot. We should remember that the St. Vincent's Declaration of 1989, we have still not achieved 50% reduction in the diabetic foot amputations. But all this together, the understanding of biomechanics, the preventive strategies would definitely help us in this achieving this goal. Thank you. Thank you, and please take care. Save the foot. I can take some questions if there are any. Thank you very much.